This is a whirlwind tour of infection. I'm a cardiothoracic radiologist, and my goal has always been to educate everyone on the lexicon of cardiothoracic radiology. I think all of you know radiologists who will say patchy opacities, infectious inflammatory, cancer not excluded, right? That's a common dictation for x-rays, and we are better than that. And I think the lexicon that we use in our reports really tells a lot about how much you love the material and your love for radiology itself. So in this talk, I'm going to show you some morphologic characteristics of disease. I'm going to use the lexicon. I'm going to show you the actual entities, right? Because I think we all know that organisms can be so hard to actually grow out and culture, right? A lot of times we say, we think it's pneumonia, and then we never get the follow-up, all right? But I think almost every slide has the answer on it in terms of what organism to reward you for your usage of the lexicon. Okay, so this is sort of the typical PA radiograph where someone could say, oh, I see some patchy opacities. And for me, I don't know what patchy opacities mean, because if you look at many of the books, the lexicon for patchy means scattered, which is fine. I see scattered irregularities on that chest x-ray. But what word would you use to describe those scattered patchy opacities? Would it be reticular? Would it be nodular? Would it be reticular-nodular? Because if you use those words, your differentials start to narrow. Your idea of what this could be, right, really start to take off. Same thing with these two CT scan images on the right, all right? This, all right, could be just called a consolidation, but I think we all can see that there's a ground glass halo around it. It's also peribronchial vascular in its location, meaning it's sitting on the vessels and airways. That's one of our most powerful sort of descriptors for bad organisms. And I'm going to describe to you what I consider bad organisms. I'm not an infectious disease radiologist, all right, an infectious disease doctor, but I do have a wealth of interdisciplinary conferences with both infectious disease as well as transplant infectious disease. So, these are very smart individuals who it's not enough for me to say, I think this is fungus. They'll look at me and be like, which one? And I'll be like, okay. And same thing with this. Oops. I don't see the marker. Yes. So these obviously are tree and bud opacities in the lower lobes, and we could think that these are aspiration, all right? But so much of our differentials also comes from maybe taking 5 seconds to see where the patient is from, what their symptoms are. I'm not someone who digs through the medical record and takes half an hour before I read a case. I sort of like to look at it first, and then I take 2 minutes to look in the record to see if there's anything interesting. This patient was actually from Texas, all right? And I don't think most of us would know that this is actually blastomycosis, all right? It was read out as aspiration, which I see why, all right? But the patient's sort of home state really gave away what it was. Okay. When we see an abnormality on X-ray or CT scans, all right, we know that there is a wealth of algorithms for nodules. Too many, right? Oh, how are we going to follow this nodule? Can I ignore this nodules? Lung-RADS 1, Lung-RADS 2.2, Lung-RADS 2022, right, by the American College of Radiology. There are a wealth of algorithms. Unfortunately, there really isn't an algorithm for pneumonia, all right? So what I like to take away from this, and this is Lung-RADS 1, right? This is the Fleischner Society, which tells you how to follow up some nodules. This is actually something I use in the hospital today, because if you sit with me, I think this really explains what a cardiothoracic radiologist does every day. Oops. I look for infection. I'm not getting there. There we go. I look for infection, I look for cancer, and I deal with nodules. All right, it's 3 columns. And in general, you know, this is what I do every day, and then I also look at cardiac studies. And so this gives sort of the trainees who are joining me for the first time, this gives them a framework of how we're going to follow some things. I mentioned LungRad's 2022, and I wanted to show you that they have finally addressed what to do with an infectious or inflammatory process. Almost similar to mammo, we're going to give it a LungRad 0, all right, and we're going to recommend 1 to 3 month follow-up. You can see that before, all right, using Fleischner, all right, we were doing somewhere between 4 and 6 weeks. So the answer is somewhere between 1 month and 3 months, depending on access to imaging, depending on how hard it is for the patient to come back to you, right? Depending on the risk factors. Obviously, if any of you had a pneumonia, we would just hope it's a pneumonia. And you know, I believe the white paper for community-acquired pneumonia says a pulmonologist doesn't have to re-image if he really thinks this is a community-acquired pneumonia, as opposed to if he has someone who, you know, has a smoking history of 100 pack years, he's probably going to get serial radiographs to ensure that that pneumonia goes away. Okay, so I wanted to mention when I first started as an attending, it was explained to me why in New York City and in Boston it's around 4 to 6 weeks. And it's all about the fact that if it turns out to be cancer, they want a treatment plan and tissue enacted by 12 weeks. So you think about it, an abnormal X-ray at week 0. They come back in 4 to 6 weeks, the X-ray is still abnormal. Within 2 weeks to a month, they get a CT scan. They see lymphadenopathy, they see suspicious things for cancer, they put a needle in it, all right? And then hopefully within 1 to 2 weeks, by 12 weeks, they'll have had tissue and be able to determine what the treatment options are for that patient. All right, so there is some clinical input as to why we pursue follow-up of pneumonia in 4 to 6 weeks. This is an old paper by a UPenn chest radiologist who basically estimated that in his experience, pneumonia could resolve 90% of the time within 8 weeks. All right, so you can see, and I used to joke around that in the wasteful United States, we're only allowing 75% of pneumonias to resolve, right? So if you think about it, that means that 25% of the pneumonias we're seeing just need a little bit more time, and it's a waste of imaging, all right? And then I used to make a joke saying, in Canada, they're too smart to do this. They would probably wait the 8 weeks. And then after that lecture, a Canadian resident came to me and said, in Vancouver, we do 4 to 6 weeks. So you can just see that even in a socialized medicine in Canada, they also do 4 to 6 weeks. Okay. If that abnormality doesn't change, what do I do on the X-ray? Then obviously, I have a standard sort of lingo where I say, you know, pulmonary consultation, depending on if there are lymph nodes, PET CT, histologic analysis, etc. So why are we trying to sort of catch some of these bad bugs? All right, this was a patient whose AIDS history was withheld from me. And luckily, one of my colleagues described this and said, they have a peribronchial vascular distribution with a subtle ground glass halo. I think this is invasive aspergillus. The pulmonologist said, I don't know, I don't think so. And then he said, come on, can you please just image in a short amount of time? And it was supposed to be around 4 to 6 weeks. But within 9 days, the patient started spiking fevers and having hemoptysis. And you can see the growth, all right? Nothing grows faster than infection. And this was invasive aspergillus. And one of the things that I tend to talk about, and it's not because I'm going to be a cowboy about these things, is if you are careful and you have great clinicians, oftentimes you'll figure out, at least in the thoracic world, that it's a lung cancer, all right? I give tremendous, like 10 centimeter masses. I will give them a period of 1 to 3 months to resolve before we pursue histologic analysis. You just have to, all right? Because there's going to be so many false positives for abnormalities that turn out to be infection. So this is an infection talk, but I did want to show you some of the other stuff that we love to look at, the bunch of white that we tend to deal with every day. And obviously, using descriptors, you would hopefully get to the diagnosis, right? Kaposi's, we all know, flame-shaped peribronchiovascular ground glass halo. Those are all sort of the buzzwords. Organizing pneumonia, reverse halo, right? You would use those words. Bland infarct, all right? I know all of us were taught in medical school about a wedge-shaped peripheral opacity, but I always quote this paper by the French where they studied 2,000 infarcts, and they actually said that this subtle sort of central ground glass was more specific for an infarct than wedge-shaped or peripheral. So you can think about all the non-contrast chest CTs. If you see this sort of almost reverse halo, but not as clear as this, you can start thinking about what are the risk factors for bland infarction for this patient. Lastly, this is that adenocarcinoma that looks like a pneumonia. This is a mucinous adenocarcinoma. Obviously, this is someone who we said this is a pneumonia, follow up in 1 to 3 months. It didn't get better, and eventually they bronched, and it was mucinous adenocarcinoma. So again, I said I'm not an infectious disease physician, so I tend to use words that are a little bit against the grain of infectious disease. So I sort of break up my organisms to typical and atypical, all right? We know that our typical organisms are our bacterial organisms that any clinician would throw standard antibiotics at it, whether it be strep, staph, Klebsiella, right? Maybe some anaerobes, gram-negatives, et cetera. But the atypical organisms, what I do in the hospital and what I love to sort of deal with and sort of dissect are these, right? The funguses, the viruses, mycobacterium, rare bacteria, and parasites, all right? And there are some examples there. So imaging of typical and atypical pneumonia can be sort of divided into, is there just a large lobar consolidation that we would think is going to be a bacterial pneumonia, all right? Or are there ancillary features that we can describe that hint that this may be atypical? Now, I have a bullet down here that says 10% of bacterial pneumonia will have central lobular nodules and ground glass associated with it. We know that we're not going to be 100%, particularly when the infectious disease people are asking me, what fungus do I think this is, all right? And that's why, I tell them, this is a guess, but I think this is going to be an atypical organism such as mucor. When I mentioned tree and bud nodules, we know that this is, if you draw the secondary pulmonary lobule, we know that the bronchiole is in the center of the secondary pulmonary lobule. We know that irritation of that airway should spare the fissures and the subpleural surfaces. So we want to see a crisp black line around the pleura and the fissures. Annoyingly, admittedly annoyingly, the bronchiole has 2 manifestations of irritation. And they get actually 2 different differentials. So if you see central lobular ground glass nodules, right, it's still a central lobular distribution. There's still sparing of the subpleural surfaces. You'll have to trust me that the fissures were spared. You're supposed to say bird fanciers first. You're supposed to think of hypersensitivity pneumonitis first, all right? As opposed to tree and bud nodules, which depending on where the patient is from, where you're practicing, you can go all over the place, right? Is it going to be a virus such as RSV? Is it going to be endobronchial tuberculosis? Is it going to be MAI, all right? So you can see that the bronchiole does have some overlap in terms of the differential of when it's irritated, but if you see central lobular ground glass nodules, you're supposed to think about bird fancier's lung first, and if you see tree and bud nodules, you're supposed to think of maybe endobronchial tuberculosis or MAI. I mentioned lobular ground glass as another feature that we commonly that we uncommonly see in bacterial pneumonia. And this is actually, I like this case because this was PJP, all right? It's the worst PJP ever because, obviously we were like, it's not pretty. It doesn't have the interlobular septal thickening, the crazy paving that we like to see, all right? But the history was very compelling. The history was high-dose steroids for many months, all right? But I just wanted to show you just 3 slides on what we're looking for, that sort of hint that we're not dealing with a typical bacterial pneumonia. I referenced the secondary pulmonary lobule. We know that the lymphatics and the pulmonary veins are in the periphery of the secondary pulmonary lobule, and we know that the pulmonary arteriole and the bronchiole are in the center. Any central lobular nodule, whether it be ground glass or tree and bud, 99% of the time we're going to think it's the airway. It's very rare for it to actually be a manifestation of vasculitis. Okay, micronodule distributions, all right, and this is from, I give credit to this UCSF high-res disc. I thought this was very helpful. I've mentioned before that I stare at the fissures and I stare at the subpleural surfaces, because if the fissures and the subpleural surfaces are involved, I know it's not central lobular, right? Very common sort of question that's asked is that. Random is another way of saying miliary. We know that micronodules measure from 1 to about 3 millimeters, so really it is a miliary pattern, all right? And these 2 slides reference the fact that the central lobular distribution can be round ground glass nodules or V and Y-shaped opacities. And you can see here the differences between the differentials of, once you decide what pattern it is, the things it could be. What are other features to remember? All right, cavitation. Now, I really want to plead with you to really use the word cavitation carefully and that you really mean it. Because to most clinicians, cavitation is like saying spiculated, right? Cavitation means, do they think it's TB? Do I have to put the patient in a positive pressure room? Do you think it's squamous cell cancer? What do I need to do? All right? You don't know how many times Pulmonary has come down the next day after struggling to put the patient in a positive pressure room, and they said, yeah, cavitation was described last night. Do you think it's cavitation? I'm like, no, sorry, it's just a dilated bronchus. All right? And if you're not sure, give the pulmonologist an out. Say, I think it's a dilated bronchus and unlikely to be cavitation. All right? Then you give them an out to decide what to do for the patient. All right? So cavitation is a very powerful feature of aggressive organisms. So is a peribronchovascular location. Right? We did micronodules. Peribronchovascular is for macronodules. Halos, halos and reverse halos can also be indicative of atypical organisms. Okay. I can't give a lecture on pneumonia without addressing Mycobacterium. And we know that Mycobacterium, 90% of primary TB is in children. All right? And I used to tease all the medical students saying, yeah, the only time I ever see primary TB is when the med students in their 4th year decide to travel the world, and then they come back and they have primary TB. In general, I don't encounter primary TB because I'm not a pediatric radiologist. I see reactivation. But one of the interesting things about primary TB or its appearance is this last bullet, is that in AIDS patients, in patients who are profoundly immunocompromised, all right, the reactivation tuberculosis looks like primary TB. All right, so I've had countless older AIDS patients whose reactivation TB had matted necrotic lymph nodes and a non-cavitary pneumonia, right? That's classic for typical primary TB, all right? But that's what my AIDS patients look like when they have reactivation. So this is an AIDS patient, and you can see he has necrotic lymphadenopathy, all right? Very characteristic. We know that this kind of lymphadenopathy, fortunately in the chest, has a differential of 2 things, right? Squamous cell and tuberculosis. That's it, all right? Very easy. We don't have to get fancy, right? And they have to sort it out. Obviously, if you would ask if I said, listen, you know, if this is primary TB, you know, this person should have a travel history. If this is reactivation TB, this patient should be profoundly immunocompromised, all right? If this is squamous cell cancer, well, hopefully this patient has a history of smoking, and we can sort it out. This, I love this x-ray, and it is a true story. This is the x-ray of a bus driver in New York City, and on one of the most popular bus lines for tourism. And I think all of us are like, uh-oh, you know, like there's a cavitation over here, there's small little nodules everywhere, all right, and this is his CT scan, and this is his reactivation TB, and it really was a bus driver in New York City. What about miliary TB? We know that miliary TB, oftentimes the x-ray looks almost normal, and it can be very tough for us to sort of decide that there are little nodules here, all right? So there's no shame in missing miliary TB completely, unless you were to say, oh, I think I see something here, and maybe it's like hazy ground glass, all right? But my colleague who practiced during the AIDS epidemic in the 80s, he took one look at this, and he was a neuroradiologist, and he goes, this is miliary TB in an AIDS patient. I'm like, come on, I don't see anything, all right? And he was right, because look, this is the patient's CT scan, and you can see the beautiful miliary nodules studying the fissures and studying the subpleural surfaces, all right? This cannot be perilymphatic, all right? We know that perilymphatic should particularly involve the fissures and the subpleural surfaces, and that's indicative of sarcoid, right? This is basically on every square inch of this patient's lungs, there are micronodules. That's going to be miliary. Okay, Mycobacterium, tuberculosis, we've done. Now we go to avium complex. Just as a show of hands, is this endemic in your countries as it is in my country? Or is this a phenomenon that we're just seeing in the United States? So this is an epidemic in the United States where we have a wealth of thin, coughing, older ladies, generally with bronchiectasis. And to treat this successfully, if you're symptomatic, it's actually 3-drug therapy. So you can think about 3-drug therapy for 15 months. So no one completes the treatment. So basically, for the last 20 years of their life, if they're symptomatic, they're coughing, they're losing weight, they have bronchiectasis. And we know that if you have bronchiectasis, you're predisposed forever, right, to Pseudomonas infection and to a wealth of particular organisms. So this is, you know, a typical MAI patient with silhouetting of the right heart border and the left heart border, so we know something's going on in the middle lobe and lingula, right? Let me go back. And then you can localize on the lateral view that there's some sort of opacity all in the region of the middle lobe and lingula over here. And then on the CT scan, on the CT scan, you can see that there's bronchiectasis and tree and bud in the middle lobe and lingula, and a little bit of tree and bud in the right lower lobe as well. MAI, you know, what I can tell you is this sort of MAI is not as scary as the classic infection. The classic infection, unfortunately, is cavitary disease. And I just told you before, if I see cavitary disease, I have to consider squamous cell cancer. I have to consider tuberculosis. This is a 24-year-old female who never left New York City and presented with this lung abscess, right? And she was ruled out for a whole host of things. They said, oh, you know, maybe this is tuberculosis. It's not going to be cancer. She's too young. Is this someone with GPA, right, presenting with 50% of GPA, or what used to be called Wegener's, is cavitary? It was all ruled out, and it came back MAI. And it was such a virulent strain of MAI that the CDC flew her to National Jewish in Colorado. They did a lobectomy, and they flew her back because they didn't want her coughing around anybody. So it's very scary, and this is classic MAI. So non-classical MAI is what we see every day. That's the bronchiectatic form, and the cavitary form is classic. And now you can imagine she was 24, so we didn't have to entertain cancer. Imagine when they're 80 and they have emphysema, and they have lymphadenopathy. and then we're going to be really going crazy trying to make the diagnosis. So, such as this patient here, all right, everyone can see the emphysema. We have a process that goes through fissures, all right? We all know that if something goes through the fissures, right, fissures are meant to contain infection. And if something goes through the fissures, we're supposed to think of bad bugs, tuberculosis, mycobacterium, funguses, and such, and cancer. So you better believe that I dictated this as likely a cancer, all right? You can see what he was doing, right? How many times do I see this? And it's not cancer, all right? But this turned out to be MAI, right? And that's fine, in terms of the fact that great for the patient that it wasn't cancer. But look at this patient. This patient had a history for 20 years of MAI, the non-classical form, bronchiectasis, tree and bud. And she comes in one day with this. And so, of course, again, we're saying, all right, well, I guess we're going to have to consider all these things. But we know that MAI, patients can get both manifestations of MAI at the same time. So they can have the bronchiectatic form and the cavitary form at the same time. So at least in this patient, we were able to work from the idea that this is probably all MAI, as opposed to this patient where we all thought this was cancer or fungus. Okay. So now we're going back to non-mycobacterial disease, and we're going to concentrate on sort of the manifestations of typical and atypical infection. So I'm going to speed through some of these. So let me see the time. Yep. So for typical infection, I think all of us would say, there's just a community-acquired pneumonia in the left lower lobe. Unfortunately, the CT has a bit of ground glass, but I wanted to tell you that I told you 10% of bacterial pneumonias can have ground glass. This came back as pneumococcus. Okay? How about this? Complete consolidation of the right middle and right lower lobes, right? Boring imaging, all right? Came back Pseudomonas. How about this? You better believe that I dictated this as like, this is terrible. This patient, has like funguses and viruses. I don't know what this is. Look what it came back, all right? MRSA and E. coli. Again, 10% of bacterial disease can have atypical manifestations of imaging. What about cavitary disease and aspiration? We know that our mouth organisms are very sort of cavitary inducing. So anything that's cavitary and it's in the lower lobes, of course we should consider aspiration, all right? And we may even see tree and bud from the actual aspiration as well. So, but I think all of us know that as we get down to the diaphragm and we see tree and bud and cavitary disease there, we should think of aspiration, particularly if the patient's edentulous, all right? So I will sometimes look at the head CT and be like, look, no teeth, all right, definitely aspiration risk. And this was Enterobacter on the left and mixed gram-negative and gram-positive cocci and rods on the right. Okay. What about atypical pneumonia? All right, we've been talking about MAI, mycobacterial tuberculosis. What about the other manifestations of atypical pneumonia? So I've already described peribronchovascular distribution of consolidation and nodules, whether they're sitting on the vessels and the airways, cavitary or non-cavitary. We should think of bad bugs, all right? If you think about it, all right, and I showed you that explosion of fungus that happened in 9 days, there's no harm in you saying, does this patient have risk factors? Could this be fungus? All right, so please describe peribronchovascular distribution of nodules and consolidation as possibly atypical. I already went through the fact that they can have miliary nodules and some ground glass, and that they can have tree and bud. So I mentioned PJP. This is a better example of PJP, all right, with the interlobular septal thickening, the ground glass, and the pneumatoceles of PJP, all right? Obviously, this is something that is very classic for test purposes for PJP. This is a coronal image showing you miliary nodules, basically from the top all the way to the bottom, studying the fissures, all right? And then here is the tree and bud. All right, so this is sort of on one slide, all the manifestations of atypical infection, and as I promised you, here are the answers, all right? Look at how small these peribronchovascular nodules are. Do you know how scary nocardia infection is for the infectious disease service? All right, it's a very, very virulent organism. What about histoplasmosis, all right? This patient was from, I believe, Puerto Rico, so that helped us, all right, because we sort of expanded our differential for peribronchovascular ground glass and consolidative opacities. PJP, I told you, tuberculosis. What about this one? Mucor, all right? Mucor in a stem cell transplant patient is almost death, right? It can be, if they don't get it under control, and I'll show you a case, they can die within 2 to 3 weeks. And that's the bread mold, right? Remember in medical school, they would talk about the bread mold fungus that could kill patients, particularly if they're immunocompromised. That's Mucor. And then this is that case of blastomycosis from a patient who was from Texas. So besides tuberculosis, miliary nodules can be very hard to see, even on CT. All right, sometimes we're using MIPS, all right, maximum intensity projection images, to really find our miliary nodules, all right? And this one, all right, the quants were negative, but they threw antifungals on it anyway, and it resolved. All right, so we don't know what fungus this was. All right, but this one, you can see using our MIP images, multiple miliary nodules. This turned out to be actinomycosis, all right? Remember that bug. That bug is very famous for particular things. It likes to be sort of empyema necessitans and rip through the chest wall into the sides of, the flanks of patients. All right, but this was actually miliary actinomycosis. This one I know it's on MIPS, and maybe you believe me, maybe you don't, but here are some nodules that were seen, and this one was histoplasmosis as well. This one here, I think this was an AIDS patient also with miliary nodules, and this turned out to be Candida. RSV, all right, so RSV is sort of taking over the world right now because everyone was wearing masks and staying away from each other now, and now we're not masked, and it can be a ubiquitous sort of virus. It can be quite a taxing virus, particularly for children, and stem cell transplant patients. So this is a stem cell transplant patient who he was a personal friend of mine, and he called me to the scanner because he wanted me to read his scan with him, live. And I said, all I see is this little bit of tree and bud and this one ground glass nodule. And he goes, you don't understand. I can't talk. I can't move without coughing. And we know that the virus is all in the tracheobronchial tree, right? That's where the infection really is. This is the little bit of stuff that we're seeing in the more peripheral lungs. But this poor man, he basically just could not function, and he was riddled with RSV infection. I like this slide. I've been showing this through the pandemic, and I told you I have some very just amazing infectious disease colleagues who give me a wealth of organisms, and they said, hey, Lagasso, that ground glass that you said may be like, viruses, just wanted to tell you that there was 4 viruses, all right? And this is pre-pandemic COVID, all right? And you can see it was corona, rhino, flu, and CMV all at the same time. And how are we supposed to know that? Well, just look. There's ground glass. There's tree and bud. We should have said viruses, all right? And we were right. This patient here on the right, maybe some of you would be like, oh, there's like scattered like nodular and consolidative opacities. It's more, I would have read this more as possibly atypical organisms just because it's so multifocal. All right, think about our bacterial community-acquired pneumonias. It's usually just like 1 or 2 consolidations. It's not going to be bilateral scattered stuff. Right, and this was rhino and entero. Going on, all right, onwards, and we have to address funguses. And this is one of my, I guess, my favorite organism because it's what we sort of are asked to exclude every day. And we know that it has very compelling images that we're asked to sort of deal with both clinically and on tests, all right? So what is this called when you throw antifungals at it and it does this? What is this called? That means it's getting better, right? So this is actually the air crescent sign, all right? Or you can, so it's actually cavitating, and that means it's better, all right? So these were solid nodules that eventually cavitated because the antifungal agents were making it get better. Their neutropenia was coming up, and they were able to battle the fungus. There are also examples of halos, all right, where fungus is so interesting because it invades the basement membrane, the capillary bed, and causes bleeding. All right, and that's why you get these ground glass halos. You can also get infarcts. All right, and this we thought was going to be a PE, this was a bland infarct, but this patient's lungs look like this. So inevitably, we chalked it up to a septic infarct, but they still got a PE study, and there was no PE there. This is what I heard some of the answers for my question. This is an aspergilloma on the left, and this patient, all the way on the left, he had PJP, chronic PJP, and had pneumatoceles from the PJP. And then Aspergillus decided to go in there and live there. All right, so you can imagine that this is someone who he would literally say, I feel things moving around as I'm walking down the street in my chest. All right, and these are bilateral aspergillomas. As you read about Aspergillus, you'll hear about chronic necrotizing aspergillosis. This is a very scary chronic cavitary disease. Oftentimes they have to go to surgery to make the diagnosis. You can imagine that it's so cavitary and necrotic, they don't even see the fungal elements on a core biopsy. They have to take and scoop out the whole thing to call it CNA. Allergic bronchopulmonary aspergillosis, if you have a cystic fibrosis population, we talk about the finger and glove sign, right? That's a very famous radiologic term. And we know that a small percentage of those with ABPA, it can be hyperdense on non-contrast CT scans. So if you can look here, all right, this is a non-contrast chest CT. You can see how bright that is. Aspergillus makes manganese. All right, so this is actually manganese, right? We know that fungal sinusitis is bright. All right, I'm showing you that fungal bronchitis and bronchiectasis can be bright as well. All right, so this is from manganese. So when Dr. Tesorius talks about fungal sinusitis, you can say, that's manganese, Dr. Tesorius. Mucormycosis is the bread mold that we talked about, and this is exactly what I was mentioning, that my infectious disease people are very scared when we are suspicious for mucor. One of the characteristics of mucor, besides cavitation, all right, is what I showed you before, bland infarcts. It almost looks like there's like ground glass in the center. All right, it can look like septic emboli, right? So this is rhizopus, this is mucor, all right? But this here, and they can have even a halo, all right? But according to the infectious disease literature, the least common manifestation of mucor has a halo. It most commonly has a reverse halo. So look at this case, this poor 21-year-old with this consolidation with this little central ground glass, right? Reverse halo. So unfortunately, I had to say, I think this is mucor. And of course, they freaked out and they were like, oh, we got to get this under control. What's going to happen? And you can see in 1.5 weeks, okay, mucor invaded the pulmonary artery. Mucor invaded the aorta. All right, you can see, and this is a 21-year-old. We consulted cardiac surgery and such. What can we do? And they said nothing. All right, so within 1.5 weeks, you can see how mucor, and you can even see that little area of ground glass in the center right over here, and then all of this is just expansion and reproduction of mucor. PJP, again, I said I was going to give you better examples of crazy paving, interlobular septal thickening that we can see sometimes in edema, sometimes in hemorrhage, sometimes in PJP. All right, so obviously this is someone who with chronic steroids and has titers for PJP. These are the chronic pneumatoceles that they can be sometimes cavitary and thick, or sometimes they can be more cystic. So I was going to make a joke that I really didn't show you any COVID, right? I showed you a coronavirus from 4 years ago, and maybe you would think, oh, this has got to be COVID because he hasn't shown anything from the pandemic. But I'm so old that this is actually from the swine flu epidemic. Does it look any different than our COVID x-rays? No, of course not. People have been predicting that viruses would destroy this world for a very long time, right? And this is one of them. I think this is in the 2005, 2007 was our swine flu epidemic in the United States. Okay, just very quickly, just to show you some COVID, we know that the organizing pneumonia of COVID can look very much like some of the features I've shown you for atypical infection. So it's very difficult for us to sort of separate, hey, is this organizing pneumonia? I need you sure it's not fungus, all right? You can see how organizing pneumonia can be quite nodular, all right? So unfortunately, there are overlapping features. These are some unknowns to test sort of, we're almost done, to test the conclusions of what I've sort of tried to throw at you today. So look at these nodules. They're peribronchovascular, right? They have a ground glass halo. So according to what we've discussed, we should consider atypical organisms. And I've done mycobacterium, I've done fungus, I've done viruses, I've done aspiration, mixed flora, and such. What's missing? Right, so again, it depends on where you practice and where this patient may travel to, all right? So what about the one on the right, all right? Multifocal consolidations, reticulonodular opacities, right? It's very busy. There's a lot of nodules here. Again, this would suggest, there's no, the heart's not enlarged, there's no pleural effusion. This is multifocal pneumonia, possibly of atypical etiologies. So both these patients, these are two different patients, had parasites, all right? This was a very famous case, which just shows you the brilliance of American tourism, where this person went to Egypt, and I've been to Egypt, and when I was there, they said, yeah, don't go in the Nile River, don't get splashed with the water, because there's parasites in there. This person didn't believe them, and he dove into the Nile River and did some laps. And then while he was in Egypt, he started spiking fevers. And then he went home, and he grew out schistosomiasis, right? And this is a subacute schistosomiasis, Katayama fever. This patient on the right was from a western province of China, and lived on a farm, and this was strongyloides, all right? And this is just, supposedly this is not even a BAL, this is just a deep spit. So you can imagine all the worms she was just riddled with worms. Don't forget about parasites. It is something that unfortunately we have to deal with from time to time, particularly in patients who have stem cell transplants. The strongyloides organism is actually very interesting. It tends to just, once it's inoculated you, usually by your feet, by bare feet, it doesn't need to leave your body. It can just be within your gut and stay there for the rest of your lives. And then we've had patients who, when they were prepped for stem cell transplants, all of a sudden it comes out. And it's called strongyloides hyperinfection syndrome or something, with a mortality of 80%. All right? So it really is something, wear your shoes. We all love grass, all right, but wear your shoes. What about this? All right? So this patient, in case you're curious, we did not do a head CT first. He did not present with seizures. This patient presented with fever and had peribronchovascular nodules. And of course, we said, oh, atypical organisms, consider fungus, consider such and such. And then I think in-house, he did have a seizure. And then they saw the calcified lesions, and this was toxoplasmosis. All right, so I think I'm on time, 44 minutes. Do you have any questions? All right, so if I can just stress, peribronchovascular, central lobular, and branching nodular opacities, that will get you, and ground glass opacities, that will get you to atypical organisms. You don't know how thankful your pulmonologists and your infectious disease people will be when you speak their language and sort of say, yeah, I think this may be, this may be fungus or an atypical sort of kind of